Hello, everyone. Welcome to this webinar that we have prepared for our colleagues at Uzbekistan. We are very happy to be here and share some of our experience and share some doubts and practices that we might help with your headache practice there. I'm sure that we have some more people coming in. I would like to know if everybody who is participating here, where are you from? So if you can just put in the chat, what's the city you're coming from? And if you're not from Uzbekistan, also share with us what is the country you're watching this webinar from. Of course, everybody's welcome to participate here. And today we're going to talk about some basics of headache practice. So the diagnosis of secondary headache, diagnosis of primary headache, and after that, the treatment of migraine. And for that, I am very thrilled to welcome here Dr. Roberta Messina, who is neurologist and assistant professor at Vita Salute San Raffaele University in Milan, in Italy. She's a member of the Education Committee of the International Headache Society and has, besides the extensive experience in practice, a lot of contribution to the scientific headache field. And also, we will welcome our colleague, Dr. David García Azorín, who is neurologist and assistant professor at the University of Valladolid, and is also a member of the executive board of the Spanish Society of Neurology and chair of the secondary headache special interest group at the International Headache Society. And having said that, we're going to start thinking about how to diagnose and and exclude the most important secondary headaches. So if you can, please, David, share your screen and we can start our webinar. Just a quick reminder, please, everyone who's watching this webinar, during the presentation, if you can use the tool of Q&A to send your questions to David, to me, and to Roberta. After we finish all the presentations, we are going to discuss and try to answer the best we can all the questions you send through the Q&A. And if you have any other comments, you can share with us in the chat. So welcome, David, and please, the stage is yours.
Thank you, Marcio, for this kind invitation, and hello, everyone. It's an honor to be here with you, and I will enjoy with you this afternoon for us, in which we will review diagnosis of secondary headache disorders. Those are my conflicts of interest. And first of all, we should remind that when we differentiate and classify a headache disorder, the main dichotomy is between primary and secondary headache disorders, depending on the underlying cause of the headache. And there are 7 categories of secondary headache disorders, such as cranial trauma, cerebrovascular disorders, infections, intracranial disorders like tumors, problems of homeostasis, substances. So there are many different causes of secondary headache disorders, and this is a challenge. But when we differentiate and put all the secondary headaches into the same group, we should keep in mind that they are not equally menacing, because there is a subgroup of secondary headache disorders that are particularly important, which are the high-risk secondary headache disorders. And what do we understand as a high-risk secondary headache disorders? Well, those are the ones that can kill you or that can cause a permanent morbidity, like blindness or sequela, long-term sequela. So when we evaluate a patient with a headache disorder, one of our priorities is to identify and promptly treat patients with one of these entities. And one of the challenges is that there are so many different causes of high-risk headaches. If we go to the international classification, only in the classification there are 118 different causes of high-risk headaches. So this is really challenging because we have to do a comprehensive evaluation and try to do our best to roll out most of them. What can we say about epidemiology of secondary headache disorders? Well, the truth is that this will depend on the setting. It is not the same whether we are in a headache outpatient clinic or an emergency department, and it may be also influenced by the setting. Those are some examples of epidemiological studies that we have conducted in our headache outpatient clinic or in the emergency department or in a rural African setting. And as you can see, the epidemiology is highly influenced on the setting. But still, if we remember which were the causes of secondary headaches like cranial trauma, cerebrovascular disorders, non-vascular intracranial disorders like tumors, infections, and so on, if we take into account that those disorders are very prevalent in the population and the proportion of patients with those which will experience headache is substantial, at the end of the day, the prevalence of secondary headaches is very high. So what we have learned so far is that there are multiple causes of secondary headache disorders, which may be highly menacing, and they are quite prevalent. And one of the problems that we have to face is that sometimes a secondary headache disorder may look like a primary headache disorder. This is an example of a study that we did with patients with headache attributed to influenza, in which what we did was to evaluate whether patients presented clinical features typical of primary headache disorders like migraine and tension type headache. So what we saw is that many patients with a secondary headache disorder may have a headache with a clinical phenotype very similar to the phenotype of a migraine or a tension type headache. And you know that there are many fancy studies from Copenhagen and also from London and other settings in which people provoke migraine attacks by using different triggers. And this is a beautiful pathway in which at the end of the pathway, similar mechanisms will be activated. And if we take into account that in the case of some secondary headache disorders, we can also observe migraine-like headache phenotypes, this suggests that secondary headache disorders are a beautiful opportunity to better understand the pathophysiology of primary headache disorders. And in secondary headache disorders, we know pretty well which is the underlying cause and which are the problems that the secondary cause is producing. So it's important to keep in mind that the secondary headache disorders do not have usually a specific headache phenotype. In many cases, they may look like a primary headache disorders, mostly like a tension type headache. And this is the concept of a mimic, a secondary cause that may look like a primary headache disorders. In this table, you see that almost every single secondary headache disorder has been reported into the literature as with the clinical phenotype of a primary headache disorder. So keep this in mind and be careful because they can mimic like a primary headache disorder. So the $1 million question remains, how do I diagnose then a secondary headache disorder if the clinical phenotype is not specific? Well, it's the time for red flags. And what are red flags? Well, there are many lists of red flags in which what we can do is to identify items that are more likely associated with a secondary cause rather than with a primary headache cause, like secondary headache disorders. And I like the list of secondary headache disorders, red flags, but I think it's more important to remember which are the typical clinical syndromes that we observe in many of these secondary causes. One of them is meningeal irritation syndrome, in which what we see is that patients with something that produces meningeal irritation, like bacteria or a subarachnoid hemorrhage, will experience a headache that will worsen by routine physical activity. This will provoke that the neck muscles will become rigid, and they will avoid any head movement. And if we torture the patient, we may elicit the meningeal irritation signs. Many of those patients will also have vomiting, not always preceded by nausea, and it's quite common also to observe photo and phonophobia. And remember that the two main etiologies of meningeal irritation syndrome in the context of secondary headache disorders are bacteria, which are like an infantry army, and the second one is subarachnoid hemorrhage. And in the case of a spontaneous subarachnoid hemorrhage, the rupture of the aneurysm will produce a hyperacute meningeal irritation syndrome, which is also known as thunderclap headache because of the hyperacute onset of the headache. One of the other traditional syndromes that we observe in patients with secondary headache disorders is intracranial hypertension syndrome, in which there will be an orthostatic pattern of the headache in which the patient will worsen when they lay down. And this will be one of the causes of the headache waking up the patient at night, because when you lay down, the intracranial pressure will physiologically be increased, and if you already have some cause of intracranial hypertension, this may produce like a worsening of the headache. Also, another important finding that we can observe in patients with intracranial hypertension syndrome is the presence of papilledema, also sixth cranial nerve palsy in the case of the syndrome, and the patients may also have sometimes vomiting not preceded by nausea. Which are some causes of intracranial hypertension syndrome? Well, one of them is idiopathic intracranial hypertension, but also some other disorders like space-occupying lesions will behave within intracranial hypertension syndrome, and patients may experience a new onset headache or a change in a pre-existing headache. Those patients with a space-occupying lesion will not improve with treatment, so there will be likely some degree of treatment resistance and progressive worsening. And as I said, this is one of the causes of a wake-up headache. But in the case of a wake-up headache, not always patients will have a secondary cause, because as we will see in a minute, some patients with primary headache disorders may also have some red flags. So this is nice, but now something that we have to keep in mind is that secondary headache disorders are changing, and the clinical presentation of the patient may reflect the evolution on what is happening inside of the patient's head. For instance, a patient with cerebral venous sinus thrombosis may have a intracranial hypertension syndrome because of the cerebral venous sinus thrombosis. But if the patient begins with other symptoms like seizures or focal signs, this may reflect a complication like a venous infarct or an intracranial hemorrhage. So we have to pay close attention to the clinical symptoms of patients with secondary headache disorders. And can we be reassured that most of these patients will have some red flags? The truth is that one red flag can be associated with multiple causes of headache. And the one beautiful example is thunderclap headache, which is probably one of the most famous red flags. How many causes of thunderclap headache do you know? Well, in the literature, in a systematic review published in 2014, there were 119 different causes of thunderclap headache. The most typical ones are subarachnoid hemorrhage, but also like reversible cerebral vasoconstriction syndrome is quite common too, and many others. So this represents a challenge because one single red flag may be associated with multiple causes. And if red flags are not specific, are they at least sensitive? Well, we tried to evaluate the sensitivity of the red flag list SNP-10 in a study that we did in our emergency department. And what we observed is that all patients with secondary headache disorders had at least one red flag. So every single patient with secondary headache disorders had red flags. The problem is that most patients with primary headache disorders also had some red flags, and none of the red flags had a perfect sensitivity, neither 100% specificity. So this remains to be a challenge. And what we can take as a take-home message is that if you doubt or you are concerned about your patient, it is always better to study the patient and to do exams and keep an eye open rather than assuming that the patient will likely have a benign cause of the headache. And what it is recommended is to do a comprehensive evaluation. Of course, if you suspect a specific cause of the headache, such as cerebral venous sinus thrombosis, because the patient had a predisposing disorder, okay, you can do the specific tests. But if you are not fully sure about which is the cause of the secondary headache, in general, it is recommended to do a parenchymal evaluation. You should also assess the cerebrospinal fluid composition and opening pressure, which is very important. And you should assess both the arterial and venous system. And keep in mind that the CTA usually evaluates arterial system, but not the venous system, and not always the cervical vessels. And if all of these remains normal, you should go for an MRI. And sometimes it may be necessary to repeat the studies in case that they look normal, to see what may fail and which may be the reason for the normality. And what about treatment? Do we treat all secondary headache disorders similarly? Well, one important message is that secondary headache disorders may respond to acute treatments that are commonly used in primary headaches. So the response to the acute treatment does not mean that the patient has a primary headache disorder, because some secondary causes may improve with some with some primary headache disorders therapies. And this is good because as soon as we diagnose the patient and put the specific treatment, we will be able to alleviate the suffering caused by the headache. And more importantly, you must do the specific diagnosis, because many secondary headache disorders will have a specific treatment, and some of them are time sensitive. So the sooner you diagnose them, the better for the patient and his or her prognosis. So to sum up, what we have seen is that there are multiple causes of secondary headache disorders, which may be highly menacing for patients' lives. They are frequent and prevalent in the population. Secondary headaches may mimic a primary headache disorder phenotype. This is the reason why we should look for red flags. They can respond to acute treatment, which may be good for us because we can give some drugs for patients, but they may have a specific treatment that we should look for and start as soon as possible. So to conclude, the take-home messages that I wanted to transmit to you are that secondary headache disorders are really prevalent and in many settings are the top one priority, like in the emergency department. The number of possibilities in which a headache can manifest as a phenotype are limited and sometimes may look like a primary headache phenotype. If you are not reassured, it is always better to study the patient, and we should not hurry to put a label of a primary headache disorders, and the red flags are more sensitive than specific. With this, I thank you for your attention, and I will be happy to take any questions.
Thank you so much, David, for your amazing and very interesting presentation. We all, I like to think that when I'm listening to a patient, especially in the emergency room, the first thing to do is to rule out secondary headaches, but also in outpatient clinics, we are always thinking about these red flags while we are here in outpatients or seeing the neurological examination. We have two questions here. I'll go through them so you can answer, and then we can go on to the primary headaches and we answer the other questions in the end. So once again, for everybody who's participating in this webinar, you can send your questions through the Q&A session in the bottom of your Zoom app. The first one, both are from Zioda. And the first one is, are there specific secondary headaches that are more prevalent in certain age groups or populations?
Yeah, one of the items of the most red flags lists, such as the SNP-10, is old age. This is a bit controversial, and we can say now because the three of us are young, but according to that list, old age is above over 50 years old. And this is because some headache disorders are more frequent in older patients. The most important probably is giant cell arthritis or temporal arthritis. And if you refer or you evaluate a patient with a new onset headache in an old aged patient, you should always do a erythrocyte sedimentation rate and C-reactive protein, because in most patients is usually elevated. But also older patients are exposed to some other increased prevalence of other disorders like intracranial neoplasms, also cerebrovascular disorders. So in a new onset headache in an old patient, it may be tricky. Theoretically, in the other pole of the age span, very young patients may be also exposed to some specific headaches. I have limited experience with children because we only see patients older than 14 years old, but in very young patients may be challenging to do a very accurate diagnosis because of the difficulties in obtaining the anamnesis. So.
Amazing. And the second question I'll ask to you, David, and then if Roberta wants to also complement, what protocols do you recommend for the emergency departments for triaging the headache patients?
In my opinion, I think that a headache in the emergency setting should be always a priority, because if it is a secondary headache disorder and it tends to be a high-risk headache, you should diagnose and treat the patient as soon as possible, and this will prevent mortality and morbidity. So if the patient has any red flag, you should do the most comprehensive possible workup. If you have a clear idea of the possible secondary headache, you can go to the specific tests that are needed to diagnose that. But if you don't have a very clear idea of what can it be, then you should do an evaluation of the parenchyma, cerebrospinal fluid opening pressure and composition, and also the vascular system, including both arteries and veins, and if possible, an MRI. If you don't have a 24-hour MRI available, then probably you should hospitalize the patient and do the MRI the day after or so on. And I said that headache should be a priority because if there are no red flags and the patient has a prior history of migraine, for instance, the sooner that you initiate the treatment of status migrainosus, the better. This will be covered in the in your presentations, but I think that we shouldn't park patients with headache disorders in a corner of the waiting room, because that will be harmful for them because of the noise, lights, stress. So the sooner that we will treat them, the better for all of us.
It's not that if you rule out secondary headaches, it's all sorted out. You still have to jump and try to optimize the treatment for primary headaches, right? And Roberta, do you have any insights about this triaging?
Yeah, I totally agree with what you have said. Probably in the emergency department, as David said, it's not so easy, for example, to request the MRI. So probably starting with a CT scan and then, yes, prioritize, for example, admitting the patients then to do the MRI. But yeah, I totally agree with what you have said.
Perfect. I would just add that looking at the reality of general hospitals, most of these patients will not be seen, at least firstly, by a neurologist. So despite we discussed this and all the importance of having the understanding of secondary causes and red flags, I think there is a step which is as neurologists working in general hospital to keep a continuous education program at emergency departments for nurses, or most of the time triaging these patients, and for the general, clinicians who will most of the time see these patients. Most of these colleagues, they have very limited education about headache, and they will have trouble identifying these secondary headaches. So I think it's part of our jobs to try and foster this education at the emergency departments, because this is very important, both to recognize secondary headaches and to understand when it is a primary headache, which is going to be our next field. So thank you very much, David, for your participation. We know how important, how special is the moment for you. And we are very happy to have you here for sharing us your experience. And it's such great presentation.
Pleasure. Thank you.
Okay, so we move forward to the second step. And I really think when we are seeing a patient, two steps. The first one, we try to understand if this patient might be a patient presenting with a secondary headache, but fortunately, most of these patients will not have a life-threatening condition promoting their headaches, which doesn't change the fact that they are suffering and they might have a very important burden in their lives because of their primary headache. So it's very important also to understand how to diagnose these primary headaches. These are my conflict of interests. So I think we can jump to this conclusion that if secondary headaches are diagnosed mostly by the changes in the red flags in history and the physical and neurological examination, and they are confirmed by the studies, which might be neuroimaging, parenchyma studies, vascular and lumbar puncture mainly, but also sometimes laboratory testings. Primary headaches, they do not have biomarkers for their diagnosis currently. So this is a reality that we face that might change at some point and are likely to change at some point, but this is not the case for now. So the most important thing is to understand that primary headaches are going to have their diagnosis promoted by a very good history. But there is also this phrase which circulates, and there's not a clear author, that in headache, history is never given by the patient. It has to be taken by the physician. And it's challenging because most times when we look at the patient, we ask for the most important questions. The patient will respond to you in a way that if he's asked again in the second day, it's going to change. So it's the headache history is a bit like clouds. Every time you look at them, they look different. This is a phrase from one colleague of us here in Brazil. And I think it's very appropriate to show the challenges of taking this history. And so to try and minimize the difficulties of a history, a proper history to arrive at this diagnosis, we have to prepare a structured interview. We have to ask some very important questions. But of course, this history taking is not only a data request. It's not that we are going to have a yes or no number of questions and we will understand what's going on. It's very important to understand that while we are asking and looking for the most important information of red flags, of the characterization of primary headaches, we are also establishing a rapport with this patient. So this might be quite challenging because there is this thing of not interrupting the patient immediately, but also you have to find a way to drive the conversation to the important questions that you might ask. And many times when you start your history taking with the patient, there is going to be a lot of noise, things that the patient might think that are very important. For example, to describe exactly all the places that they feel the pain. And you have to listen to what the patient is telling you, but many times this is not the information that is going to drive you to the proper diagnosis. However, he's going to tell you also the important information. And if he doesn't, you have to be prepared to actively look for and ask them. So one thing that I think I like to think, and this is in the literature, is to, when you listen to the patient, you have to establish what is the pattern of headache that he's telling you. And there are some common patterns of headache that we are going to also understand better if we know some characteristics that are fundamental for the diagnosis. So the location is absolutely crucial. If you think about a cluster headache, they're going to present with the specific location. If you think about secondary headaches such as arterial dissection, you have more common regions of headache. The intensity is very important too. The duration of the headache. The time to peak will tell you if the headache is a thunderclap or if it's a very intense headache, which is not a thunderclap, which may be many times the case of a migraine patient coming to the emergency department. And the recurrence is also very important for us to understand the pattern. So there are these established simple ways to think about pattern. Of course, in real life, not always we're going to be able to define like this, but a recent sudden onset headache is one that is both very intense and very fast to onset. So this is a clear pattern that you have to think about secondary headache, because this is the image of a thunderclap. Of course, not all of them will have a secondary cause, as David already mentioned, but this have to urge our thought about a secondary headache. Also, a recent progressive headache. So what is recent? It's not like 5 years of progressive headache. We're talking about days and weeks of progressive headache. This is something that also should urge us to think about secondary headache. In the meanwhile, we will find many times patients presented with recurrent paroxysmal headaches, which is more the phase that we're looking for thinking about primary headache. So a migraine patient, a patient will report to you that he has, or of course, or she, a very important headache, with high intensity, but many times they will tell you that they have had in their life many episodes like that. And it's important to understand that in between these episodes, these patients are headache-free, they recover completely. So this is an important information that we are looking for. But sometimes they come at a point that they do have chronic daily headache, so they do not recover in episodes. So important also to understand if they started as episodes or if they already started as a chronic daily headache. This might also help us to understand where are we working at. And in the end, of course, these patterns, they do not set the diagnosis, but they are a start for us to think about what a specific primary headache this might be. Of course, there are other symptoms that we have to rule out or try to understand that this patient presents that will help, that they will fund actually the diagnosis. For example, photophobia, phonophobia, nausea. Even though these are not specific of migraine, we can see these symptoms in secondary headaches. As we saw, we can see these symptoms in other primary headaches, such as cluster headache. They might be present, but these are important symptoms. They are cardinal for the diagnosis of migraine. And for example, they're not commonly present in patients with tension type headache. Autonomic symptoms might be present too, especially when they are localized to an eye or hemiphase. This might help us to understand, to drive to in the direction of a trigeminal autonomic cephalalgia. Restlessness is also something that is very much a behavior of patients present with, for example, with cluster, and it's not very much common in patients with migraine. So, of course, after trying to investigate how is the headache, what is the pattern, what is the localization, intensity, time to peak, we try to see if there are other features accompanying the headache, and we once again think about the red flags that we already mentioned very well. And also think about differentials. A patient might present to us with more than one primary headache. And all of this is a patient who has a history of migraine, and all of it starts a cluster headache, not a rare scenario. And if we, many times this patient will not understand that he's presenting with a different primary headache. Sometimes they will think are just presenting with a more intense patient of what they already have. And think about differentials is always important. In the end, this is how we establish the diagnosis, understanding what are the features of that headache and what is the past history of this patient, if there is a pattern that is coming to this diagnosis consultation. And once we do have this information, we go to the tool that we used for the diagnosis, which is, of course, the ICHD, the International Classification of Headache Disorders. Currently, we are in the third edition, and there is a website and access to trying to have a quick look at all the diagnosis criteria of this, both primary and secondary headaches. And when we're talking about primary headaches, we divide in a very much for the education. It's not that this is a pathophysiological division, but we do have these four big groups of primary headaches. The first one, migraine, which is mostly going to be the most prevalent condition in the neurologist office. It's not the most prevalent one. The one is tension type headache, but most of the times patients with tension type headache do not look for assistance, at least with the neurologist. And also the third group, which is trigeminal autonomic cephalalgias, which will have inside different conditions, such as cluster headache and micrania, the short-lasting trigeminal autonomic cephalalgias. And finally, the fourth group, which is not exactly an homogeneous group, but where more rare conditions are included, as headache or hypnic headache and other types of primary headaches. We're going to focus now in migraine. How do we diagnose migraine? So this is what the ICHD-3 look like. You will have criteria for migraine with aura, migraine without aura, chronic migraine, probable migraine, and other conditions which are more less common in our practice. Looking at the diagnosis criteria for migraine without aura, what we find is a patient that presents with at least 5 attacks fulfilling the criteria B to D, which are, so these attacks, they have a proper duration. They are not very short attacks with like 10 to 15 to 30 minutes duration. Usually will take 4 to 7 hours to improve. Of course, the treating these might reduce this time. So if you have a patient with a headache and they take a treatment and they improve in 30 to 60 or 180 minutes, this does not include the diagnosis of migraine. But if not treated, the headache on migraine will last for 4 and usually up to 2 hours. Many times this coming to another diagnosis, status migrainosus, as we mentioned. Also, this patient will have some other characteristics. So he has to present at least with 2 of these characteristics, which are a unilateral location, pulsatile quality, moderate to severe intensity, and aggravation by routine exercise. And sometimes you have, this is a tricky one, because if you ask the patient if he has an aggravation with physical activity, they might respond to you no, because they actually are avoiding any type of physical activity. So we have to keep in mind that avoidance of routine physical activity is also a criteria here, and it's very common that this patient will have this behavior. Also, we have to attend to these other criteria, which will have 2 options. Either the patient presents with nausea or vomiting, either of them attend, or the patient presents with photo and phonophobia. So if we attend to 2 of these first 4 criteria in one of these 2 criteria, and there is no better accounted reason for this headache, or which means there are no red flags, because as David quite well highlighted, many secondary headaches will be presenting with pulsatile quality, worsening with physical activity, nausea. So it's not that only presenting with the symptoms we are set with the diagnosis. We also have to think and rule out secondary causes by the red flags. But most of the times, we're going to meet these patients without any red flags and with proper symptoms to diagnose a migraine patient. Sometimes, though, we're not going to find all of these criteria. So, for instance, if you attend to 2 of these 4 criteria in C, but we do not have a patient presenting with nausea or vomiting, photo and phonophobia. Example, patient presents only with phonophobia, no photophobia, no nausea. This is a patient who will receive the diagnosis of a probable migraine. And many times, this is something that in the follow-up is going to present. And we have also to understand that the way we ask patients, we might induce them to a certain type of answer. If I ask a patient of mine if he has photophobia, the understanding of phobia may not be something very familiar for that. So a slight photophobia, which is a slight discomfort in normal light presentation, might be not understood by the patient as a photophobia. So we have to really try to give a time for the patient to think, to understand. And also another thing is about the emergency department. Of course, sometimes you see these patients with a clear behavior of photophobia, closing their eyes and putting something in their faces. But sometimes they do not do that. And if they have a very intense pain, sometimes we will have a better history taking after some relief with proper treatment. So sometimes, of course, we have to try and take a history the most we can to start a treatment. But sometimes it's useful to, after the treatment with analgesic, we come back and ask these patients some more questions. And then migraine with aura, which is diagnosed by these episodes that fulfill or either visual, sensory, speech or language, motor, brainstem, or retinal aura. And they have at least 3 of the 6 characteristics, which are at least 1 aura symptom spreads gradually over 5 minutes. So it's not something that sets in the complete vision, patient stop seeing or has a blurred whole visual field vision. It's something that spreads along the time in their vision field, for example. 2 more aura symptoms occur in succession. For example, patient starts with visual aura and then has a sensory aura or a speech disturbance. Each individual aura symptom lasts from 5 to 6 minutes. So it's not something that lasts seconds, nor something that lasts 5-6 hours. At least 1 aura symptom is unilateral. Sometimes patient will tell you that they have only one side vision, but of course they do not know the concept of visual field, which and the transition that we have in the optical chiasma. So, but seeing the aura in one part of the field will, for example, this unilaterality. Sensitivity is the same, and at least one positive, which, for example, in the vision or the visual aura, this means that patient is seeing something rather than only not seeing. Not only blurred vision, but they see stars, they see fortification spectrum, for example. And aura is accompanied or followed within 60 minutes by headache. So if the patient attends to 3 of the 6 characteristics, the aura is well defined, and we have diagnosis of migraine with aura. The chronic migraine, I just want to point to one thing. The diagnosis, when we have at least 10 days of headache a month, and at least 8 days of these 15 days for at least 3 months, will attend to the criteria of migraine. So this means is we understand that patients with chronic migraine will have many days of headache that do not attend to all the criteria of migraine. This is absolutely what we expect from patients with chronic migraine. But of course, to set this diagnosis, they will have also those days with criteria for migraine, or at least they respond to triptan or a derivative of ergotamine. Status migrainous is when we do have the migraine condition that extends for over 72 hours. And finally, I think it's important for us to understand that migraine is a condition that will not present only with the symptoms that we consider for the diagnosis criteria. We do have to be aware that patients might present with prodrome symptoms such as yawning, concentration, mental slowness. Very commonly, we're going to find neck and pain, stiffness, sometimes photophobia, nausea, food cravings. Understand this might help us to better arrive to the diagnosis in some challenging cases. Then aura, we already commented, and the phase of headache patient we present with those very characteristic symptoms. Also, the postdrome, where the patient present quite often with asthenia, tiredness, somnolence, difficulty in concentration, and cognitive difficulties. So understanding this broader picture from the migraine attack, it's important for us to achieve the diagnosis. I'll focus finally in the diagnosis of trigeminal autonomic cephalalgia, especially in the cluster headache, which is the most common condition among this trigeminal autonomic cephalalgia. We do have the criteria, and here what we have to, what you're going to look for is a patient that presents with severe. It's not a moderate, it's not a slight, it's a severe or a very severe unilateral, orbital, or supraorbital, or retroorbital, or even temporal pain that lasts, and this is very important, from 15 to 180 minutes. So it's not something that will last 4 to 72 hours. Just be aware that many times these patients will have, in between their attacks, they will have residual headache, a slight headache. So at first, the patient may respond to a question of duration, saying that it takes hours to relieve. But you have to keep on asking if they have peaks, if you have suspicion of a cluster headache. They are very intense and are in between 15 to 180 minutes. Also, they will have to one of these two criteria. At first, at least one of the following symptoms or signs: conjunctival injection or lacrimation, nasal congestion and or rhinorrhea, eyelid edema, forehead and facial sweating, and meiosis or ptosis. So these are autonomic symptoms that we are looking for, ipsilateral to the pain, or a patient might present without these symptoms, but with a sense of profound restlessness or agitation. And if you ask this patient of cluster and he does present with restlessness, he will answer you in a clear way. Also, another thing that is important for the diagnosis is the frequency of episodes, which comes from 1 every other day to 8 episodes a day. So this is how we do the diagnosis of cluster. And it's very important to understand that if you arrive to the diagnosis, we have to send this for the AT treatment, either with oxygen or triptans, especially cutaneous sumatriptan or zolmitriptan intranasal. And this patient might be set in preventive treatment. Usually the most used is verapamil, but we have also the nerve blocks, anticonvulsants, especially topiramate and galcanezumab, as well as lithium as options. Finally, this one I'll talk about, not because it's less important, but because it's the one that we usually will see less, is tension type headache, which is not something that is caused by psychological tension, rather a headache that is felt tension. A patient will present with at least 10 episodes lasting from 30 minutes to up to 7 days with bilateral location, pressing or tightening quality, mild to moderate. So we're not talking about severe intensity, not aggravated by routine physical activity. So you see, it's a bit based on the idea of migraine. So when patients do not present any of those characteristical symptoms of migraine, usually they will have this diagnosis of tension headache, no nausea, no vomiting, no more than one of photophobia or phonophobia. So this will lead us to the diagnosis of tension type headache. So in conclusion, it to take the history of patients with of headache, especially in the emergency department, but also in our clinic. We have to set the pattern of the headache. We have to look for the characteristic of the primary headaches so we can understand the classification criteria. Do not limit to the classification criteria, understanding the broader picture of this primary headache to make the right questions. And then once we have the diagnosis, we are able to offer these patients a proper treatment. And so with this, I conclude my presentation, and we will go on to Roberta's presentation. You can keep on putting your questions in the Q&A session. And after we finish Roberta's presentation on migraine treatment, we go and answer to all the questions. So welcome again, Roberta. You can share your screen.
Perfect. Thanks. Thanks, Marcio. Thanks also for the invitation. Okay. Can you see the screen?
Yes, okay. I can see, and now in presentation mode. Thank you, Roberta.
Okay, perfect. So good afternoon, everyone. It's a pleasure for me to be here. So in this last presentation, we are going to discuss about how to treat migraine. So we are going to be focused on treatments for migraine. These are my disclosures. So when we talk about migraine management, we need to consider that we have two approaches, which are acute treatments and preventive therapies. The main goal of acute treatment is to stop as early as possible the acute migraine episode, while the main goal of preventive therapies is to reduce the frequency of migraine episodes. And now we are going to discuss these two approaches in more details. Starting with acute therapies, as we said, the main goal of acute migraine treatments is to stop as early as possible the migraine pain. And according to international recommendation, to define whether an acute treatment is effective is usually we take as like cutoff if the treatment is able to stop the migraine pain within 2 hours from the intake. But also we know that, and as we have just seen with Marcio's presentation, that the migraine attack is not only characterized by the pain, but there are also other symptoms that may be bothersome to patients, for example, the photophobia, the nausea. So it's also important that an acute treatment is also able to reduce and improve most bothersome symptoms associated with pain. Another important aim of acute therapies is that to avoid headache relapses, and so to leave the patients with migraine freedom for the 24 hours following the intake of therapies. Another important recommendation that we should bear in mind, that we should tell to our patients, is that acute therapies need to be taken as early as possible. So there is evidence showing that acute treatments are more effective, and so there is a higher chance that the acute treatment is going to be effective if they are taken as early as possible, and usually if they are taken when the pain is still mild. Also, we need to consider that if the patient has taken acute therapy, but then there is a headache relapses, we should recommend or to increase the dosage of the therapy, or to change and to switch to another way of administration, or in some cases, if the headache relapses are very frequent, to switch the type of drug. So which are the acute therapies that we can recommend to migraine patients? If the patients have mild or moderate attacks, so attacks with mild or moderate severity, we could, for a first-line treatment, recommend non-steroidal anti-inflammatory drugs and non-specific analgesics, so drugs like ibuprofen or diclofenac or acetylsalicylic acid or paracetamol. So these are first-line treatments that should be recommended for those migraine episodes that have a mild to moderate severe. However, if patients do not respond to these first-line therapies, we should recommend some migraine-specific treatments, for example, triptans. We know that triptans are the first migraine-specific therapy that have been developed. They work targeting the 1B and 1D serotoninergic receptor. We have a different type of triptans that are available. Most of them are available as oral tablets, but for example, for zolmitriptan and rizatriptan, there is also available tablets that are oral dispersible. So for example, these ones could be preferable if the patients report having a lot of nausea or vomiting during their attack. There's only the sumatriptan that is also available as a subcutaneous injection at 60 milligrams. And as we can imagine, so this is the most rapid, so the injection has the most rapid onset of action. However, we need to bear in mind that triptans are contraindicated in some subgroup of patients, and especially in those patients who have cardiovascular or cerebrovascular conditions, or in those patients who have uncontrolled hypertension. So triptans are contraindicated in this type of patients due to their vasoconstrictory effect. If a patient take and use one triptan and the triptan is partially effective, so it responds on 2 or out of 3 attacks, we should consider increasing the dosage of the triptan or switch to a different type of triptan, or eventually also to switch and change the mode of administration. However, if a patient fail up to 3 different type of triptans, we should consider to change to another drug. Luckily, nowadays there are other migraine-specific therapies that are available, and these are the gepants and detants. Gepants are oral tablets and they work targeting the CGRP receptor, while the detants works targeting the 1F serotoninergic receptor. For the gepants, there are two types that are available as oral tablets that are ubrogepant and rimegepant, and in the USA it has been also approved one gepant that is available as a nasal spray, that is the zavegepant. For the detants, on the other hand, we only have available the lasmiditan, which is available in different dosage coming from 15 to 200 milligrams, and an advantage of using gepants and detants is that these drugs are safe and can be used also in patients who have cardiovascular or cerebrovascular contraindications, since they do not have a vasoconstrictory effect. And also these are very well tolerated treatments in general, especially the gepants. For the detants, we need to bear in mind that since they can cause vertigo and dizziness, there is a precaution that if the patients take detants, they should avoid driving for 8 hours after the intake. So to summarize this part regarding acute treatments, we could recommend for mild or moderate, so for episodes with mild or moderate severity, we could recommend first-line treatments such as non-steroidal anti-inflammatory drugs or non-specific analgesics. But for moderate to severe, for episodes of moderate to severe intensities, we should recommend some migraine-specific acute therapies among triptans or eventual gepants and detants. If a patient have a history of stroke or cardiovascular disease or cerebrovascular condition, we should not recommend and prescribe triptans. However, as a first-line treatment, we could recommend paracetamol, or if this first-line therapy is not effective, we can recommend lasmiditan or gepants. In this subgroup of patients, we also should bear in mind that if we use non-steroidal anti-inflammatory drugs, we should use them with caution, especially if patients take also antithrombotic therapy. Regarding ergot derivatives, which were the very first migraine-specific treatment that have been developed, nowadays they are no more often so used because they can have very severe side effects in terms of cardio and cerebrovascular diseases, because they have an important vasoconstrictory activity, and also they can lead to fibrosis, and also they are associated with a very high risk of overuse of medications, so they should be avoided, and the other option we have just discussed should be preferred. Also, opioids should not be recommended for the acute treatment of migraine, since they can also increase the risk of overuse and addiction, and also because there are not so much evidence supporting their effectiveness in the relief of the migraine pain. Moving now to the section of the preventive treatments. So when we should start a migraine preventive therapies in our patients? The international recommendation suggests that if a patient have more than 4 migraine episodes per month, and or if these episodes are even less but are very disabling, and for example they do not respond to acute treatment, in all these these cases, we should start and recommend migraine prevention. And which are the aims of migraine preventive therapies? As we have said before, the first goal is to reduce the number of episodes that occur per month, but also to decrease the severity of the migraine episodes, the severity of the pain, also to increase the efficacy of acute migraine treatments, and of course, overall to improve the quality of life of our patients. Regarding preventive therapies, the first treatments that have been developed and have been available are first-line preventive therapies, and actually these therapies were originally developed for other conditions, and even if there are not so many randomized controlled trials that have studied the efficacy of these treatments in migraine prevention, actually the clinical experience collected and observed over all these years that these treatments have been used supported their use as migraine prevention. So these therapies included antihypertensive treatments such as beta blockers or candesartan, but also antidepressants such as amitriptyline, antiepileptics including topiramate and sodium valproate, and also other classes like calcium channels blocker, like flunarizine that is available in some countries. So all these therapy may have some side effects, and specifically for anti-epileptics drugs, we need to remind that since most of our patients are young female, we need to remember that anti-epileptics are contraindicated if a patient is looking for a pregnancy, because they have a higher risk of fatal alterations. So it's important to keep in mind this information. So, but which first-line treatment we should recommend to our patients? First of all, we should investigate and we should consider whether there are some other comorbidities associated with migraine that may guide our decision. So, for example, if the patients also suffer from hypertension, we could prefer using, first of all, beta blockers or candesartan, or if a patient also suffer from anxiety or depression, we may prefer recommending the start of antidepressants. This first-line treatment should be started at the lowest dosage that should be increased progressively over the time, aiming to reach the maximum and the maximum dosage that is most well tolerated by patients and that is effective. We should also recommend to our patients to try an adequate trial of treatment that should last approximately 2 to 3 months. If the patients have tried first-line therapies but did not respond or did not tolerate these therapies, we should consider moving to second-line treatments. These include onabotulin toxin A, which is an effective therapy for patients, but only for those patients with chronic migraine, so which are, as we have just seen during Marcio's presentation, so those patients who have at least and more than 15 headache days per month. So on onabotulin toxin A, there were performed some trials that assessed the effectiveness of onabotulin toxin A as migraine prevention, and these studies used a specific protocol, which is called the PREMPT protocol, that included the injection of the botulin toxin A over 31 different regions across the frontal areas, parietal areas, occipital and cervical areas. So this treatment is administered once every 3 months. It included, so as I said, 31 different injections, and it included the administration of 155 units of onabotulin toxin A that can be increased up to 195 units. it's a very good treatment and a good option for patients with chronic migraine, since it includes a local injection, is generally well tolerated, only rarely could provide side effects as neck pain or muscle weakness, but these effects are transitory and usually resolve over the months. Other second-line preventive treatments that are available and that have been developed over the last years are the anti-CGRP treatments. So there is ample evidence showing that the CGRP pathway has a key role in the pathophysiology of the onset of the migraine attack, and based on this evidence have been developed new treatments targeting specifically this CGRP pathway. The monoclonal antibodies are treatments targeting the CGRP receptor in the case of erenumab, but also we have 3 other monoclonal antibodies that are targeting the CGRP ligand, which are eptinezumab, galcanezumab, and fremanezumab. Eptinezumab is the only one that is administered intravenously once every 3 months. It's available at 2 dosages, 100 milligrams or 300 milligrams. While erenumab, fremanezumab, and galcanezumab are all administered subcutaneously. Also for erenumab, we have 2 dosages, the 70 milligrams and 140 milligrams. Fremanezumab is also subcutaneously administered, and it can be administered once monthly or also quarterly. And for galcanezumab, it includes a loading dose of 200 milligrams only for the first administration, and then it consists of monthly administration of 120 milligrams. All these monoclonal antibodies and all have been used over the last 5-6 years, and there are real life evidence showing that they are very effective treatments. The real life evidence showed that approximately 50%, 60% of patients respond to this therapy, and compared to classic first line oral preventive therapies, they have definitely much more less side effects. However, we know that these therapies are more expensive, so there are different indications, there are different rules across the world that limit and set how to use and to which kind of patients we can prescribe these treatments. Along with the monoclonal antibodies and other therapies targeting the CGRP system are GPANs. We've just discussed GPANs as acute therapies before, and indeed these are the first therapy that actually have a double indication in migraine therapy. So GPANs, and specifically rimegepant, is the one that can be used for both acute treatment and also as preventive therapy. The GPANs works targeting the small molecule that target the CGRP receptor. As I said, there is rimegepant that is available as oral tablets that as a prevention can be administered, can be taken once every other day. And the other GPANs available as migraine prevention is atogepant that can be taken every day as oral tablet. Also, these are very effective treatments. They are also very well tolerated. The only side effect that sometimes is reported with the GPANs is nausea. But when and how we should define if a preventive therapy is effective? So regarding the definition of treatment response, the international recommendation recommend to define if a treatment is effective if it is able to reduce of at least 50% the frequency of the episodes that occur during the month. However, this cutoff is reduced up to 30% if the patient has chronic migraine. So in chronic migraine, we can establish if preventive therapy is effective if the patient has a reduction of at least of 30% in the monthly number of migraine episodes. But of course, we know that our patients are more complex, and in some cases, not only we can be focused only on the migraine episodes, but in some cases, we also need to assess and evaluate the rate of satisfaction satisfaction of patients, but also if the treatment, for example, improve the pain severity, and also if we improve the patient's disability or quality of life, that can be assessed using some specific questionnaires such as the MIDAS or the IHS scores. So in general, we to evaluate if migraine preventive are effective, we should actually consider in more general the response and the improvement of the quality of life of our patients. But how long should we continue? And we should recommend taking migraine prevention. So if a patient have a good response, the international and the most recent recommendation coming from the International Headache Society recommend that for oral treatments, they should be taken for at least 6 months before considering discontinuation. For non-oral treatments, they should be continued for 1 year before stopping this treatment. And also the recommendations, the guideline recommend that patients should be considered to stop preventive therapies if they have for at least 3 months less than 4 monthly migraine days, and also based on the rate and grade of satisfaction of patients. However, on the other hand, if the patients did not respond to migraine preventive therapy, or for example, if they had very important side effects, we should consider stop one treatment and taking into account and consider to start any other option of the preventive treatments we have just discussed. We know that migraine is a complex condition, and in many cases, patients also have other comorbidities. So in some cases, pharmacological approaches are not enough. We always need to associate with pharmacological approaches also the education, specifically in terms of the management of sleep, or in terms of like recommend always a good hydration and healthy diet. And in some cases also we should associate pharmacological treatment with non-pharmacological therapies such as behavioral therapies like cognitive behavioral treatments, or also with, as I said, complementary treatments such as specific diet, or also physical therapies. And in some cases the patients could also benefit from using neuromodulation that in some countries are available, even if in most of the cases neuromodulation is also affordable and should be paid by patients. So with this I have concluded, and I thank you all for your attention, and we can now move to the questions.
Thank you so much, Roberta. Your very complete and interesting presentation. Thank you, David, for being here with us. We're going to jump for the final questions, and we conclude our webinar. Still, I request people whoever have questions to send in the Q&A session. To first address to my presentation, what are the most common diagnostic pitfalls clinicians face when identifying primary headaches like migraine or tension type headaches? I think there are several pitfalls that we might fall in. First of all, many patients, they will have an idea of what is their diagnosis that is built throughout years suffering with headache. And sometimes it might not be exactly the proper diagnosis they have. For example, many patients, they complain about neck pain and stiffness that happens before the headaches. And usually they will come to us saying that they have a cervicogenic headache. And this might not be the exactly diagnosis they will have. So I have to have this attention to not jump to conclusions of the diagnosis by what the patient first tells us. We have to be aware that patients, they do not know much about the diagnosing of primary headache, despite they suffer with this for long periods. I don't know, Roberta and David, do you want to add any other to this question about pitfalls in diagnosis of primary headaches?
No, I totally agree with you. Also here in Italy, like it's very frequent that patients come into the clinic saying that they have cervical pain, cervical problems, and they do not even consider having a migraine or suffering from headache. And what I have also observed in clinical practice, that many times, like first to arrive to a neurologist or to perform a visit with a headache specialist, they, for example, had like X-ray for the cervical spine or CT for the cervical spine. So
True.
this is a very so we use like expenses for this examination that are not useful. So I think yes, to collect a correct clinical history is essential for this.
Thank you, David.
And I would like to emphasize something that you mentioned, which is that primary headache disorders are recurrent and cyclic problems. And we should not rush to put the diagnosis of a primary headache disorder until the sufficient number of episodes have been occurred. So if you have the first ever episode of a headache like a tension type or a migraine-like headache, you should not put the diagnosis of migraine, because this may be dangerous. Because if at the end of the day the patient has a secondary cause, you labeled like a benign headache. So you should be patient, and you can say migraine-like headache phenotype, and to be observed or whatever.
I agree absolutely with you, and I think that sometimes, even though this is the desire of the physician to set the diagnosis and set the treatment right away, sometimes we have to face that we still are not really sure of what's going on. And I don't think there's any problem with sharing this with patients, that we sometimes will need some time, some follow-up to really arrive at the diagnosis. Of course, with more complex situations, many times we will arrive to the diagnosis straightforward, but I think it's very important what you mentioned to have patience and follow up patient to arrive at the diagnosis. And then Zilda added the question about the biomarkers of imaging and other biomarkers for the diagnosis of primary headache. I think Roberta is very appropriate to answer this question, but I would introduce that not for the diagnosis currently. Am I correct, Roberta?
Yeah, so yeah, I totally, even if like I'm a fan of imaging of MRI, actually for diagnosis, I think I confirm that the diagnosis is only clinical for migraine. So if we do not have a suspect of there are no red flags suggesting that there may be a secondary headache, there is no indication like requiring or performing an MRI. Also, with the King's College London, we performed a study, like an imaging study using advanced imaging with this aim to evaluate whether the imaging could provide more information in the differential diagnosis between migraine and cluster headache. And what we found was actually that the clinical information was the most important feature information discriminating the two types. So actually the imaging only for the differential diagnosis between primary headaches do not add any advantage and any value compared to the clinical history.
And even though we still don't have this as a tool, I think the importance of these studies and your work is very much a reflection of this, is to understand pathophysiology. I think in this set, we are advancing a lot with neuroimaging, right?
Yeah. It's yes, it's essential. I think the role that had the MRI and still have in understanding the pathophysiology, and also, unfortunately, we do not know very well, for example, why some patients suffer from cluster headache and have that type of specific episodes, while others suffer from migraine. Also, it's interesting that many patients, for example, that are suffering from cluster headache actually also suffer from migraine, and unfortunately, we still don't know what happens at the brain level, or what are the pathophysiological mechanisms leading to one episode rather than the other.
Mm-hmm.
But we hope that in the future we are going to know much more.
There's a lot of work to do. one is also to you, Roberta. Which, with the growing availability of the CGRP inhibitors, how should clinicians choose between traditional therapies and a newer biological?
So this is a very good question, unfortunately. So if we should not consider the cost of new treatments, I would go first with migraine-specific therapies, which are the new therapies. However, we need also to keep in mind that these therapies are some cost. So in some cases, in some countries, we cannot start, first of all, with these new therapies. So I think in this scenario, our government actually help a lot the work of the clinicians, since I know in different countries there are some rules to prescribe to when and which patients prescribe new treatments. So in that case, I think having some rules help you to decide when you can start with the new biologies. But if like in an ideal world, in my opinion, I would go first with the new migraine therapies.
So the access is something important, but the clinical data being available every day suggests that these treatments are very well tolerated, and they are effective for the prevention of migraine. To you, David, the question about the MRI findings suggestive of intracranial hypertension in patients that have a clinical presentation that does not support this diagnosis. This is a common scenario, right? How do you behave when you see this positive MRI with no clinical suspicion of IH?
Mm-hmm. This is one example of why clinical anamnesis and evaluation is the most important thing, because the probability of incidental findings in imaging is important, and sometimes they may cause more harm than benefit if we start doing unnecessary tests, therapies, and so on. So I think that the most important is the clinical presentation. Mm-hmm. MRI is may show some suggestive findings of intracranial hypertension, and if you have any doubt, given the potential risk of this condition when it is untreated, it is better to perform a cerebrospinal fluid opening pressure evaluation, because unfortunately MRI is not sufficient to diagnose idiopathic intracranial hypertension. So you have to do the LP, the lumbar puncture. And in my experience, this is quite common. And I would say that more than 90% of patients in which there are no suggestive symptoms or signs like papilledema or transient visual obscurations, neck pain, or others, it's quite unlikely that idiopathic intracranial hypertension will be the etiology. I don't know, what do you think, Marcio, which is one of your...
Absolutely agree. Yeah, I absolutely agree, because in the end, we are going to see these patients that we don't know why some of them will present with partial empty sella, and usually this is the most common finding, but sometimes they will have tortuous optical nerve and other findings that are typical, but they do have a clinical presentation. Sometimes, as David mentioned, we are going to go for a lumbar puncture, and you're going to find sometimes a normal, sometimes a slightly raised pressure, such as, for example, 21 centimeters of CSF. Does not allow us to set the diagnosis, because packed pressures over 25 centimeters. But I also think the only thing that I would add, you mentioned very well, I mean, the clinical symptoms of IH are important. Obesity is something to consider. If it's patient with obesity and positive signs, I will definitely go for the lumbar puncture. And also the tomological evaluation, the visual field is very important. One thing that I highlight, for example, is that the best evidence for use of pozolamide we have is a study that used as an endpoint the improvement of the visual field. So if you're facing a patient that has no impairment of the visual field, You have to think if you really have to do any treatment directed to hypertension. And also in the other side, it's sad that once you control the pressure of the hypertension, they will improve of their. So if it should prompt us to think about treating headaches in these patients instead of only treating pressure. So this is a complex scenario. I think we have to take very much account into the clinical presentation. And I think we're actually in the end of our presentation. I will ask the last question to Roberta, a quick comment about the special population. What should we think about when thinking about preventive in pregnant women and breastfeeding women?
So these are actually challenging cases because, so especially for pregnant women, there are no studies supporting that the therapies that are available are safe. Among all the preventive therapies, there are some evidence supporting that beta blockers, for example, propranolol, could be used during pregnancy. But in other cases, maybe it could be more a best choice could be like, for example, I didn't mention, but like the injection, for example, greater occipital nerve injection, since these are local treatment, could be more safe. And also maybe a suggestion I may give with these new anti-CGP treatments is to discuss also with young ladies if they are planning to start a pregnancy. For example, it's better to start GPANs rather than monoclonal antibodies, because we know that monoclonal antibodies have a longer half-life. So it could be like the patients should wait much longer before starting looking for a pregnancy, while with GPANs, usually since the half-life is around 10 days, 10 hours in a week, then the patients can start looking for a pregnancy. So not like very clear evidence to safe treatments to use during pregnancy, but we can have some planning strategy like to use before.
Yeah, of course, we need more studies for all these situations, and we won't have many studies because, of course, it's an ethical challenge here. But I agree with you. This might be a better options in this. I think with this we can conclude webinar. I would like to thank much first Zilda for setting this with us, colleagues from Uzbekistan. I'd like to thank you very much, Roberta and David, for preparing this very interesting presentations for clinical and being here with us. And I'd like to wish you all a very good day and hope to see you soon in the IHC in São Paulo 2025. Would like very much to welcome as much as of you as we can. And thank you.